So I'll be brave if you're brave. I'll be brave, but only if you're brave.
Good evening, everyone. Welcome to tonight's Lung Cancer Living Room. All of you in the room, those of you joining us online, we are so happy to have you here tonight for this great conversation that we'll be having about both medical oncology and radiation oncology. I know we talk a lot about one or the other, but it's not often that we talk about how they work together. So we are thrilled to be having that conversation tonight. For those of you who may not know me, I'm Danielle Hicks. I am Chief Patient Officer here. I'm already going to get emotional. I can't look at anybody in the room at GO2 for lung cancer. This program started in 2009 in this very room with my mom and I. And we're going to talk about her in a second before we get started because I need to get this out of the way. And it really started with all of you in mind. We brought a handful of you together to say, you know, what is it you need? What can you not find out there that we can create and bring to you? And here we are today with the Lung Cancer Living Room, where we bring expert speakers to come in and talk about varying aspects of the disease. And I think my problem is my sister's in the room, and I caught her eye inadvertently, and I promised myself I wasn't even going to look in that direction. Before we get started, and I want to get this piece, you know, sort of done up front because the conversation is important. It's important to me. It was important to my mom. It's important to everybody watching that you guys are educated, empowered, informed on what your options are so that you can go back and have those educated conversations with your healthcare provider about what your options are. As I know all of you in the room and most of you watching live know, my mom passed away shortly after the last living room. So the firsts are tough. And I'm trying to keep my Bonnie on right now and really pull my shit together, as she would say. But what I wanted to make sure to do was give a ridiculous amount of thanks and appreciation to everyone who has reached out, to my family and I, personally through social media. I mean, the outpouring of love has been absolutely incredible. And I think as much as we all knew, and even those of us in this room knew how much impact Bonnie had in this community, and I won't even get started on the impact she had on myself and my family personally, but I'm sure you can imagine. But I don't even think we really knew because the last 3 weeks have been incredibly overwhelming with the outpouring of love and support and recognition from this woman who has been dubbed unstoppable. So I just wanted to make sure to thank everyone from the bottom of my heart, my family's heart, the organization's heart, for all of that, because it really is what's keeping us going. And with that, I actually think I feel my tears drying up, which is fantastic. I'm sure, you know, it's not a great look, and this is on video, and it's live. But I can't thank everyone enough. It's been a truly surreal experience. My sister and I have been talking about how the last 3 weeks, because it was 3 weeks yesterday, it feels like we've been walking through mud, right? But it is time for all of us to put our big girl pants on and our big boy pants on and get back to what was important to her, and that's why we're here today. I also have gotten a lot of questions, so I just want to set the record straight, and rightfully so, questions about whether or not this had anything to do with her diagnosis, with the lung cancer diagnosis that she received back in 2003, and I can tell you it did not. I can tell you that completely unrelated. Actually, we're not sure what it was. What we do know is that she died peacefully at home in her bed. So as much of a shock as that is for all of us, because of all the times I worried that my mom wasn't going to make it through that knothole, 3 weeks ago was not it. So just to quell any fears that I know a lot of people in the community have, particularly those who have been battling and or surviving or living with this disease for a long time, lung cancer was not it. So with that, I want to get to the business at hand, because again, this is what's important, and this is why we're here, and this is why she built this organization, and in particular, this meeting. So I'm going to put my glasses on because I want to introduce at a very high level these two amazing humans who are sitting next to me, who so graciously agreed to come and have this conversation with us tonight. So Dr. Natalia Colocci, who's an MD, PhD, Barnholt Endowed Chair in Oncology, Executive Medical Director, PAFMG Cancer Care Service Line, Medical Oncology Section Chief, Sutter Cancer Service Line. It's so many words, right? I'm going to ask her to explain all that in just a second. And then Dr. Daniel Schiffner, who was here, was it last year?
Yeah, a year ago.
I think, yeah, when we were talking about radiation oncology in particular. MD, Medical Director of Radiation Oncology, Service Line Department Chair, Radiation Oncology, Sutter Health, Palo Alto Medical Foundation. So some of the objectives tonight are really for all of us to better understand how radiation oncology and medical oncology work together. Like I said at the beginning, we talk a lot about how they work independent of one another, but I think it's important to talk about the very cool ways that they collaborate to work on tackling the cancer that anyone may have been diagnosed with. And then obviously, and as I already said, education and empowerment, so that you can get a better understanding of what your options are and go back and have more informed, detailed conversations with your own individual provider. So before we get started, and like always, I'm going to ask that these two beautiful people tell us a little bit about themselves and why lung cancer is an area of importance to them. And Dr. Colocci, let's start with you.
Sure. Okay. Nice to meet everybody. So my name is Natalia Colocci, and I'm a medical oncologist. A little bit about myself. Interestingly, I went into oncology in a sort of non-conventional way. So I have a background in chemistry. So I was in college. I was trying to figure out what to do with my life. I thought, well, maybe I want to do medicine. I guess I need to take chemistry. So I took chemistry and fell in love with organic chemistry, and I said, forget medicine. I'm just going to go the chemistry route. And so then I went to grad school, and at that point, I realized that I was not made to be in the lab for the rest of my life, and realized I really want to be with people. And so that's when I applied to medical school. So I see things from the lens of chemistry, which brings me to why the interest in lung cancer. So when I did my fellowship in 2003, 2006, really the treatment options for lung cancer were very limited. It was really traditional chemotherapy, non-targeted therapy, traditional chemotherapy. And I remember in 2004, people started talking about the first mutation called EGFR mutation, and the first targeted treatment, and we can go into that later, for that mutation. And that was sort of the beginning of the explosion of new treatments targeted, and we can talk about that, and immunotherapy, et cetera, in lung cancer. So since 2004, there has been an explosion in the understanding of what drives lung cancer, and consequently in the treatments. That said, lung cancer is the third most common malignancy in the US. Breast is first, prostate is second. There are about, in 2023, I looked, there were about 250,000 cases of lung cancer diagnosed in this country, and about half end up dying. So it's obviously a huge challenge that we're all faced with. None of us is immune to lung cancer, so at about 85% of patients who get lung cancer are smokers, but 15%, and that is a lot of patients, thousands of patients get lung cancer. They've never seen a cigarette in their lives. And I do have to put in a plug here for screening. So one of the reasons why it is such a challenging issue is that there's really no effective screening for lung cancer as there is for breast cancer and colon cancer, except for people who have had a very, very heavy smoking history. People don't normally think about this, and it's something that we're actually trying to tackle at Sutter with regards to the importance of low-dose annual CT scans for people who have had at least what we say a 35-pack year history of tobacco, meaning on average, 1 pack a day for 35 years, and then you can get a CT scan. So that screen, all to say that for the vast majority of us, there is no super effective screening. So all of those things really sort of underlie the importance of us continuing to understand lung cancer and treat patients with lung cancer.
Thank you. And Dr. Schiffner, before we switch to you, I just want to make a comment, because we do talk about screening quite a bit, you know, if not every living room, a lot of living rooms, it comes up. And for those of you who haven't heard me preach this before, and maybe new to this programming, I know that screening and early detection is irrelevant to the vast majority of people who participate in programs that GO2 has to provide, right? Because we're here, you know, effectively to support people who are already diagnosed. However, you know, it is my very humble opinion that there is no one better than people living with lung cancer, people loving people living with lung cancer, and people advocating for those living with lung cancer to shout from the rooftops that screening is available. It's not perfect, as Dr. Colocci said. It's not for everyone, which is unfortunate, but we're hoping to get there. Mm-hmm. But right now in this country alone, and I won't go into the details of it, of the why this is, but there's about 16 million people who qualify for this life-saving screening, because we all know, I don't care if it's lung cancer, I don't care if it's colon cancer, I don't care what it is, if we find it early, there's a stronger likelihood of curing or eradicating the disease. And roughly, depends on where you look around the country, but 7 to 12% of that 16 million are actually activating around not only getting screened for the first time, but following protocols for follow-up screening. So it's incredibly important that somebody's talking about it, right? Because 16 million people is a lot of people.
And I don't think people know that there is screening for lung cancer, right? Everybody knows about mammograms, but very few people know about lungs, so it's super, super important.
Agreed. Dr. Schiffner, how about you? Who are you?
Yeah, so I am a local guy. I'm what you can call a hometown doc. I grew up in Atherton, went to the local K through 12 public schools, and happy to be practicing in the community I grew up in and family still lives in. It sort of adds an added layer to the mission of the work that I do with wonderful colleagues like Dr. Colocci. Why cancer medicine in general? So based on some research I did as an undergraduate at Duke, when I started at UCSF for my medical training, was really fascinated by the scientific and research and biology and chemistry and those angles of cancer medicine. But as I got deeper in the training, it was really the human dimension of oncology that drew me in. And radiation oncology really spoke to me because it's procedural. In some ways, it's surgical in that way. But it also really richly incorporates, again, that human dimension of working closely with patients and talking to them and listening to them and really having those close bonds. And so the opportunity to practice radiation oncology in my home area really is very gratifying and continues to be. And as far as like lung cancer, this is an area of particular interest. As Dr. Colocci said, this is a vast problem in the landscape of cancer medicine. One of the big three cancers in the United States. It affects younger and older patients, smokers and non-smokers, men and women. And actually in radiation oncology in specific, we're involved in treating advanced cancers from stage 3, and that there's been a lot of exciting work that makes that even more successful now with the incorporation of immunotherapy after chemoradiation. We treat a lot of early stage lung cancer through the lung nodule screening programs that we were describing earlier, where success rates for stereotactic body radiation therapy are upwards of 90%, so very gratifying to be treating and curing these patients. And even in metastatic cancer, we can play an important role in treating oligometastases, brain metastases, and of course palliation. So really on an everyday basis, really proud to be involved in lung cancer treatments.
I love that. I think, especially for some of the folks that are newer to this space, not a space or a club anybody wants to join, but for those who may not know a lot about cancer treatment because it just hasn't impacted their lives or the lives of their loved ones, I think there's a stigma sort of associated with what they think they know about whether it's medical oncology and systemic treatment or more targeted treatment through radiation therapy, about exposure and how sick and side effects and all those things people, like I said, that they think that they know. Mm-hmm. And you touched on this, Dr. Colocci, where the last 20 years in particular, I mean, we are miles and miles and miles away from where we were when even my mom was mm-hmm. diagnosed, mm-hmm. because targeted therapies, what? Like nobody was talking about that in 2003. Right. Well, they were, but it was in clinical trials. That's right. Another living room event. Mm-hmm. So I want to talk a little bit about each of your roles, what you do, what the different types of systemic or targeted type of radiation therapy is involved, how it has evolved from, it's not your grandfather's, right, or your great-grandfather's at this point, type of treatments. And then we'll jump into how you guys coordinate care in order to work together. So, Dr. Colocci, what is the role of a medical oncologist?
So the job of the medical oncologist is to treat cancer where we know it is and where we think it might be that we can't see. So if you have a chest x-ray and there's a mass in the lung or somewhere else, and if surgery cannot happen, let's say, the role of the medical oncologist is to give treatment to try to shrink the cancer where we see it on the chest x-ray. It is important to know that cancer cells have the ability to go into the bloodstream. So they sort of walk in, they invade into the bloodstream. And so we refer to that as microscopic disease. So when people say, oh, my surgeon took it all out, so I'm done. Possibly, but there might be microscopic disease, and one can figure out the probability that there might be microscopic disease based on the pathology, the disease, et cetera. And if you don't do things to try to kill those cells that are in the bloodstream now, those cells will grow and divide over the next 2, 5 years, et cetera, and then those cells will end up in other tissues, so the liver, the bones, the brain, et cetera. So the job of the medical oncologist is to give treatment to the entire body, either in pill form or intravenously, that goes where we know the cancer is and where we think the cancer might be. So we refer to that as systemic therapy. It goes everywhere in the body. There are different types of systemic therapies. So the original, or the first one that we dealt with is chemotherapy. Introduced, I think the first form of chemotherapy was nitrogen mustard in World War I. If someone is interested, by the way, if anyone of you is interested in the history of cancer, there's a book called The Emperor of All Maladies, and by Siddhartha Mukherjee, that won the Pulitzer Prize, and it was published, I don't know, at least 10 years ago. And that's the last book that I thought I would want to read, and I started it and I couldn't put it down. It is fascinating, and it talks about cancer. Did the Egyptians have cancer, and how was cancer treated in the Middle Ages, et cetera, and then it goes through the Nixon era and now. So anyway, talks about a lot about chemotherapy. So chemotherapy is one type of systemic therapy, either in pill form or intravenous. And then there are what we refer to as targeted therapies. So those are systemic therapies, either in pill form or intravenous, that target a specific, generally protein that sits on the surface of the cancer cell. And by targeting and attaching it to it, it affects signals inside the cell that then lead to cell death. So that is targeted therapy. The first form of targeted therapy are anti-estrogen pills. That was in the sort of the late 80s to 90s. So things like tamoxifen, that was the very first one. That is targeted therapy. And then since then, we've had an incredible explosion of understanding of mutations, et cetera. And with those, a whole slew of new targeted therapies in lung cancer and other types of cancer as well. So that's targeted therapy. They're not 100% targeted, meaning, and so they target other tissues as well. And so that's why you have side effects. So for instance, there are EGFR receptors in the skin. So that's why when someone takes an EGFR pill, you can have a rash. So, but there are certainly more targeted than chemotherapy. And then a third type of systemic therapy is immunotherapy, and that is relatively recent. It made a splash when Jimmy Carter was treated with what we call a checkpoint inhibitor, when he had melanoma with brain mets and was basically cured. And immunotherapy works by a different mechanism. It's given in the vein. There's no oral form of immunotherapy. And it basically tells it revs up the immune system so that the immune system fights not just the cancer. It fights the cancer. Now, sometimes it fights the cancer, but also normal tissues. And so you will have side effects from sort of the body or your immune system turning against the normal tissues. That's the third type of systemic therapy. I think those are it. Chemotherapy, targeted immunotherapy.
So just to recap a little bit, so chemotherapy was sort of the OG choice, right, of how we systemically treat cancer that has spread, or even if it hadn't, like back in the day, right? Intravenous, so IV hookup. Chemotherapy is still a great option for a lot of people for a lot of reasons. But it's really meant to attack not only cancer cells, but sometimes healthy cells. So there was a lot of side effects that potentially came along with that, and we can touch on that in a minute. Targeted therapies are what have really exploded. Targeted therapies and immunotherapies are what have really exploded over the last 20 years or so. And if you think about a targeted therapy in particular, and these mutations that you talked about, it's sort of, I envisioned it as sort of, what is the driver mutation? You guys have heard us talk about that before. Like, who's driving this cancer bus, right? Mm-hmm. So if we can identify who's driving that bus, and there is an FDA-approved therapy or sometimes clinical trials that are hoping to target maybe some newer mutations, we can effectively identify that driver, knock that driver out, and keep our cancer at bay. Mm-hmm. And there's the immunotherapies who are helpful in your body. Let's see if I can figure out a way to say this in super lay terms, but help your body to identify cells that aren't supposed to be there, that are hiding from your own body's immune system. I mean, I think, and correct me if I'm wrong, but every day we've all got cells that kind of go bad, for lack of a better word. And our immune system finds them and wipes them out, and that's it. But every once in a while, some of those cells get through and our immune system cannot identify them, right? Mm-hmm, mm-hmm. So immunotherapies sort of help our bodies to identify those cells that aren't supposed to be there. Somebody explained it to me one time, which completely resonated with me because I have 4 kids. That, your immune system also does a really great job of protecting the baby in the womb, right? Because technically that baby is not made up of just my cells, but the father's cells as well, right? And so similarly, cancer can hide
Yeah, and immunotherapy is a very broad term. I mean, you can say that vaccines are immunotherapy and gene therapy is immunotherapy, et cetera. I think when we talk about lung cancer immunotherapy, we're talking about a very specific class of drugs, and they're called checkpoint inhibitors. So the Keytruda, the Opdivo that you might have heard on TV ads, those are checkpoint inhibitors. And so the body is an incredible thing. And we have a very strong immune system, but obviously the immune system cannot be active at all times, otherwise we'd be dead, right? So there are mechanisms in the body that keep the immune system at bay, and so it's a checkpoint so that the immune system is not always revved up. So these drugs release that brake. So they are the checkpoint inhibitors, so they release that brake so that the immune system is revved up, and so that these our cells can recognize cancer cells. As I said, two things I want to point out. One is sometimes there's a lot of sort of hoopla about immunotherapy, and sometimes people think that immunotherapy is given in one institution but not another. And I get patients saying, "But do you give immunotherapy?" Immunotherapy right now is like the aspirin. I mean, we do. It's a standard of care. It's not like you have to go to MD Anderson to get immunotherapy. It's a standard of care. Number two, immunotherapy doesn't have there's a specific role for immunotherapy. You can't just give immunotherapy to all cancers or to all lung cancers. There have to be specific requirements that the pathologist sees for immunotherapy to work. Number three, just because it's immunotherapy doesn't mean that it does not come without side effects. So people think, maybe it's more natural than chemotherapy. No, immunotherapy can have life-threatening side effects. Rare, but it is possible. So all to say, to be humble and respect the toxicities of any of these medications. So we've come a long way since chemotherapy, but we still have to be very careful.
I think it's a really important point, and I know that back in the early days of immunotherapy, particularly with all the direct-to-consumer advertising that was happening, everybody was like, I want immunotherapy. Like, I've seen the commercials, this is what I need, and it's not right for everyone, to your point. So in the upfront early, and then, of course, later we'll talk about at other times where this is relevant, how important is this biomarker test? What is biomarker testing? And how important is it in determining an individualized personal treatment plan for each person diagnosed?
So biomarkers is a sort of general term that refers to a specific characteristics that gives you information about something else. As an example, you could say that cholesterol levels are a biomarker for heart disease. Okay, so there's a little bit of a correlation. Okay, another example of a biomarker is PSA for prostate cancer. So PSA is a protein that's made by prostate cells and prostate cancer cells, and if it's up, that might be a biomarker. It means that there's something happening and more prostate cells than there should be, et cetera. In lung cancer and in other diseases as well, we can use biomarker to refer to mutational status, and the technical term is NGS, or next generation sequencing. So that is looking at the DNA of the tissue of the cancer cells and looking more than 300, 400 mutations that have been identified. And some of these mutations are biomarkers for predicting response to certain treatments. So for instance, for immunotherapy, the biomarker that we look at is called PD-L1. So we stain the cells to see if they have this receptor because it's involved in the mechanism of action. And so if it's positive, then you have a higher likelihood that immunotherapy will work. We always look for a certain number of biomarkers for lung cancer, and then more, because new drugs come out every day. It's crazy. And so it used to be that we used to tell the hepatologist, can you just check for EGFR? Okay, and he would tell us, okay, EGFR. And then another mutation came along called the ALK gene rearrangement. Oh, can you add ALK gene rearrangement? Yes. Okay, can you add ROS1? Yes, we can add ROS1. Okay, can you add MET? Yes, we can add MET. And we're adding and adding and adding. And so right now, it's frankly easier to send the DNA and check for all mutations. So we do that test in one scoop, and that's called next generation sequencing. There are many companies that will run those tests. One is not better than the other. So the first one that was the famous one was Foundation Medicine, which is still very much there. But there's Caris, there's Guardant Health, there's Exact Science. They all do things slightly differently, but really you can't say that one is better than the other. And then some institutions do it in-house. So Stanford and UCSF had their own assay. And we are actually, Sutter is actually starting to think about doing it in-house. Some discussions coming along. But so it's really standard of care to send tissue for NGS right away. There are some exceptions. So if it's a really, really tiny cancer where you know you're not going to need systemic therapy, then don't spend the money to send that information because you're not going to do anything with that information, and hopefully you're cured. But as soon as the cancer is big enough, 4 centimeters or more, lymph nodes involved, et cetera, you really want to send that information. It's really standard of care, and you do it at the time of diagnosis. You can always do it later. We keep tissue. Any pathology department keeps tissue for, I think, 10 years by law, something like that. But might as well do it, at the beginning. So that's what biomarkers or NGS.
Yeah,
so,
and I think it's really important and it's really relevant, and particularly in the last few years, even in early stages, to your point, because we've found, even for patients who are surgical but do have biomarkers, and EGFR anyway, there have been approvals, right?
Right.
In what's called the adjuvant setting, treating people post-surgically with these types of targeted therapies. And we're just anticipating more and more to come with each different biomarker. So biomarker testing, like back when we first started talking about it, even in this living room, it was mostly just trying to get, education, both to healthcare providers and patients alike, that top-down, bottom-up approach. Let's just have the conversations, particularly in more rural community settings. And then it moved to, okay, at progression, we need to retest to see what has changed about this cancer. And now it's like, okay, now we need to educate on the earlier stage. So it's incredibly complex.
It is incredibly complex. And these NGS can be done on tissue, but can also be done on blood. And when it's done on blood, that's called a liquid biopsy. So that's what we mean by liquid biopsy. Liquid biopsy obviously rests on the assumption that there are enough cancer cells that you can pick up through a blood draw and identify. But the fascinating thing is that as cancers progress, they progress because of new mutations that make the cancer resistant to the current treatment. And so now what we do is at progression, we really should check and do a liquid biopsy to check, are there any new mutations that have arisen since the last. So yeah, lots of tests.
So I want to shift to Dr. Schiffner for a second and talk about radiation oncology. Again, and I mentioned this earlier, and there still is, some fear for folks about what radiation means, what the exposure looks like. Could that potentially cause side effects, other challenges? So what is your role? And then I want to jump into the combination.
Sure. So, in broad strokes, there's 3 broad areas of oncology. There's medical oncology, so treating cancer with drugs, surgical oncology, treating cancer with cutting, with surgery, and then radiation oncology, which is, of course, treating cancer with radiation. So radiation in this context is generally high energy X-ray beams generated by a device called a linear accelerator. We happen to be in an area of really ground zero for medical linear accelerators. The leading manufacturer is actually a Palo Alto-based company that we have a very close relationship with at our own practice. Radiation's been used to treat cancer since 1899, which is actually really remarkable because radiation itself was discovered in 1898. Now, of course, they had no idea how it worked and how best to deliver it and how to dose it, but it speaks to how long it's played a role long before chemo and really even in the earliest days of surgery, like pre-anesthetic. But fast forward to the 1990s, bring it more up to date. So a basic technology in radiation oncology, which is still used in a variety of scenarios, which is called three-dimensional conformal radiation therapy. So this is where we start with a CT scan of the body segment. That gives us a three-dimensional model. And we map out the radiation to target a body region. And these tended to be very simple beam arrangements, front to back, side to side, maybe front, back, and side to side, where you end up treating essentially like a block of tissue. There's no real way to control for organ motion. So in lung cancer, we know these tumors move quite a bit. So a sizable safety margin was needed. So the volumes of treatment were actually quite large, but we weren't missing the tumor. We were treating lymph nodes, we were treating the primary tumor. But when you're treating that large area, you really have to give a very tiny daily dose, typically 5 days a week, typically over the course of 6 to 8 weeks of daily treatments, because there was so much normal tissue involved that we had to be very respectful of the tolerances of those normal tissues. So fast forward to the next iteration, which is called intensity modulated radiation therapy, or IMRT. So this used multiple beam arrangements, complex beam arrangements. A next iteration of IMRT is what's called a volumetric modulated arc therapy. As the name implies, the machine's rotating continuously and giving radiation beams that are sculpted. But this let us sculpt the radiation dose to really almost any conceivable structure. You can make a smiley face, but in the case of lung cancer, you can treat the primary tumor, which is often sort of oval shape, and the lymph nodes, which is often sort of hockey stick shaped, all together, and do a better job of avoiding the lung tissue. Now, in parallel with these body-based treatments, there's a technology being used to treat brain tumors called stereotactic radiosurgery, where this has been going on for quite a while, but the paradigm was radically different. Instead of treating these larger areas with tiny daily doses, you were giving very high dose, but very tightly focused, very precise treatment, and typically only in 1 to 5 sessions. So that's stereotactic radiosurgery in the brain. Fast forward into the body, now we have really advanced technologies that let us be really focused on the areas that we're treating. So instead of just a CT scan, when we're treating lung cancer, we're typically doing a 4-dimensional CT scan where we're actually mapping the 4th dimension, which is time in this context, of how the tumors are moving, so we can really lock on to the tumor during specific phases of respiration. So that lets us tighten our margins in. The more stage 1 lung cancer we treat, the more we don't have to treat the lymph nodes at all. So in the body, we're more typically doing what's called stereotactic body radiation therapy. So we're taking those same technologies of intensity modulated radiation therapy that let us sculpt the dose, but honing in on just the tumor, giving the high doses, again, in 1 to 5 treatments to treat our lung cancers or metastases. And sort of as medical oncology is advancing, as are we in the direction of stereotactic body radiation therapy, these high doses, highly conformal, highly precisely delivered treatments have some unique synergies with immunotherapy because it stimulates some unique immune responses, which are very exciting for the field.
Yeah, I'm excited to talk about that and how the two of you work together in that capacity and others. I just want to make sure that folks understand that very simply, sort of back in the day, you had a tumor. I mean, it's in the lungs, right? You're breathing. We can't stop you breathing through this treatment. So there were challenges, right, with hitting the mark without affecting what would otherwise be considered normal, healthy tissue. So there was some damage being done. But because of technology, and we won't even talk about whatever AI might be, however that might be impacting that in our probably really near future. But what we have right now is the ability through CT scanning and like real-time visualization of what's happening and mapping and all the other things that are associated with that to really just pinpoint and target the tumor itself with very little to no damage to otherwise healthy tissue, which is huge when we think about how radiation therapy is impacting control and destruction of the disease.
Yeah, well stated. So the better we're able to avoid the normal tissue nearby, the more we can safely escalate the dose, and the more safely we can escalate the dose, the more we can give more dose per treatment and shorten those 6 to 8 week courses of radiation to typically 1 week with remarkably little toxicity in most cases.
Yeah, it's pretty remarkable and insane. Does somebody have a question? Sorry. Yes? No? I thought I saw hands. Michelle, are we good online? Okay. I do want to remind people that you can ask questions as may be relevant to your current situation or fears you might have about a future situation throughout this. So I want to move into, I want to state that we're going to talk a little bit about the brain in a minute, because we know that lung cancer, particularly advanced lung cancer, likes the brain. And so we've come leaps and bounds from where we were, even 20 years ago with how we treat brain metastasis, and you touched on it. But I do want to talk about that in a second. But first, I want to talk about how you all work together, how that care is coordinated, how you determine who needs just systemic, who needs just radiation therapy, and who needs a combination of the two. And I'm leaving it up to you guys to decide who wants to start.
Well, I can take a stab. So I would say that when you're first diagnosed, in some healthcare systems, a nurse navigator reaches out to you and tells you, this is what this diagnosis means, this is what lung cancer is, this is what we do to stage the cancer, to figure out where it is. And these are the people involved in the treatment of your cancer. And so typically those would be the surgical oncologist, the radiation oncologist, and the medical oncologist. And so at that point, referrals are made for the patient to see those three specialists. And it can happen depending on what institution you're at. It can happen all in one day, or it can happen sequentially. The key is obviously for the members of that team to talk to one another about the treatment plan, right? And typically people, so if I have a patient, a new patient comes to me and I see the chart, I will pick up the phone or walk a few feet to Dr. Schiffner's office and say, hey, Dan, I'm seeing this 65-year-old. You will see her next week. This is the case, and this is what I'm thinking. What do you think? Or heads up, you need to know, this particular history or fear that the patient might have, or et cetera, right? So we talk, and then the patient is seen by both medical oncologists and radiation oncologists. And if it's a case that is not completely straightforward, we will present the case at tumor board. And so tumor boards, you typically happen once a week, and you submit the case. And at tumor board, there's a whole multidisciplinary team made up of medical oncologists, radiation oncologists, surgical oncologists, pathologists, radiologists, or review the images with the radiologist, the slides typically with the pathologist. And then there are not just physicians, there are the non-physicians, essential members, equally essential members of the team, who are the social workers, who provide additional help with regards to social issues, and sometimes financial navigators who help you manage the finances of treatment, sometimes palliative care physicians, depending on the stage. And so that case is discussed at tumor board, and then we come up with a plan. And then we basically show the plan to the patient either that same day or another day. But the key is just talking to each other, right? So we talk to each other, not just looking at the chart, not just looking at the patient, but it's really what makes us tick, right? So yeah, so I would say.
And I think that one of the things that I love about what you just said, and one of the things that we preach here on the regular at the Living Room and in other programmatic areas, is this conversation, the multidisciplinary team, the tumor boards. Like not everyone's, I should say, treatment is the same. It is individualized to the person diagnosed, to the cancer that they have been diagnosed with, to where the cancer is, how it's behaving, all of that, right? And I think it's such an important piece that we know, and I say this a lot, like, for those of you in the room, we're in Northern California on the San Francisco Peninsula. Like, we have access, a lot of us have access to really to quality healthcare and to healthcare providers who have the benefit of access to the information that they need on the regular to keep up with what's happening. But that's not necessarily what's happening around this country, and we hear it all the time, right? Whether it's people calling on our helpline. Sorry, Genevieve, I've had my back to you this whole time, I apologize. With people in particularly rural areas where they're seeing a general oncologist who's just expected to know everything there is to know about whatever type of cancer walks through the door, whether it be solid tumor or a blood cancer, and that's incredibly unfair. So I'm sort of tooting, GO2 and particularly our support services efforts right now are to educate you all so that you can go back. I mean, I've had patients call, people diagnosed call and be like, hey, why did I have to tell XYZ healthcare provider about comprehensive biomarker testing or about this type of option? Obviously, we don't provide medical advice. We're like, here are the questions to go back and talk to your providers about, right? And obviously, my response is always like, don't be upset about it. Like maybe you just taught him or her something that they didn't know by no fault of their own. Like, PDRs, the physician desk reference books, are like a thing of the past, right? Like, it is incredibly complex, this disease, and cancer in general. So I just went off on a big, huge Bonnie-esque tangent about staying informed and staying educated and allowing yourself, again, we are blessed where we are to have access to providers such as the two sitting next to me right now with so much knowledge about what's happening today, because things are happening so fast and furiously in what the treatment of this disease looks like, that if you're not paying attention last week, you missed something. So anyway, I don't know where I was going with that.
I would make one comment, which is ChatGPT is not always right.
Correct.
So I did have a patient who came in with her husband, and at the end I told her, so I do recommend adjuvant chemotherapy for that microscopic disease that I was talking to about. And all of a sudden she turned to her husband in tears and said, but you said the oncologist was going to say that I didn't need chemotherapy. And the husband's like, well, that's what ChatGPT said. And so anyway, so I don't know what they put into ChatGPT, but ChatGPT is not always right.
Artifacts are what they call them on all this generative AI, and we have to be very, very careful. You are not wrong. We are in the very early stages of information gathering from I don't even know how to explain it. It's so creepy. Like the whole internet thing. I think it can be very beneficial for some things, but we should definitely use caution when thinking about it for healthcare purposes.
If I can add one piece to the tumor board dynamic. So to back up a bit, Dr. Colocci and I are in community practice. We're in an integrated practice at Sutter Health at Palo Medical Foundation specifically. where really collegial relationships between providers, between physicians and our nurse practitioners is really cherished, and that really benefits the patients tremendously. It's a great place to work. It's a great place to have colleagues you really enjoy spending time with, but it's also wonderful to have the access to each other without any of the silent grudges, which sometimes you might come across in other settings. And I don't think we're completely unique, but it is very special. And then another dynamic that exists within the tumor board setting is the clinical trial. So though we are in a community practice setting, in all of our tumor boards we have our research coordinators who are actively listening and screening patients for the open trials that are relevant to them. And that's really important to make those available to our patients. And that's another piece of the tumor board dynamic that's so valuable to us and also to our patients.
Yeah, you mentioned trials, and I think, and again, those of you who are veterans to this program hear me, preach from the mountaintops about the importance of clinical trials, but not before thanking those who have come before, those who haven't participated, for their participation, because without clinical trials, these advancements simply would not be made. We would not know what we know now and have the amount of options that we have now were it not for the people that came before who participated to make that so. So a huge thank you to any and all of you who have and or are considering this, because it's because of you that these two are able to do what they're doing at the levels and with the quality with which they're doing it.
Yeah, we always think about clinical trials. That's the first thing that we think. And actually, for medical oncologists and radiation oncologists too, we have a software that helps us input the chemotherapy or targeted or immunotherapy or all of them. And then the first thing that comes out is if there's a clinical trial. For us, it happens to be Sutter. So if there's a clinical trial anywhere across Sutter, whether it's Sacramento or San Francisco or Palo Alto, and so we see that. And if the trials are not right for everyone, so a patient may not be eligible, or the treatment might not be the right treatment for this patient because of whatever, and so we can say, not interested, thank you very much, we'll go to, quote, standard of care. But that's the first thing that we always think about is clinical trials. And so just wanted to
it's an incredibly, and I'm going to give a shameless plug to GO2 for those of you who might not have the benefit of being seen at Sutter. GO2 has as I think a lot of you know, a clinical trial navigational program run through 3 of the PhDs in our science and research team that will help search based on your where you are within your diagnostic or diagnosis process, what treatments you may or may not have had prior, and they will help search for clinical trials based on your parameters. So if you're like, I'm willing to go anywhere, they'll search anywhere. If you're like, I'm willing to go 50 or 100 miles, that's how far they'll search. So our Lung Match program is really incredibly supportive for anyone looking to have those conversations with your own healthcare providers, and then obviously the trial teams. Yes, ma'am.
Do your boards outside of Sutter? Specifically, I didn't connect with my oncologist. She was absent and retired very shortly thereafter. So I switched over to UCSF. So my oncologist is at UCSF and everything else is at Sutter. Would you include my oncologist in any new?
Coordinating the care across, is that
So
what you're
yeah,
asking?
because
I see. I understand the question. So, absolutely. I would say, as a rule, my Rolodex on my cell phone has many UCSF and Stanford and other institutional oncologists who we could reach out to run by a challenging case or in the direct coordination of care as though it was with Dr. Colocci down the hallway. That happens all the time. Now, within the context of tumor board, these do tend to be institutional. as opposed to open forums. And so in the context of a tumor ward, it would be quite unusual, either in community practice or in academia, to have outside folks present. It's not typically an open forum, but the cross-institutional coordination is extremely normal. And I think one area in specific is sort of elite surgical specialty that might be concentrated outside of the community, where patients might travel quite far, even out of the Bay Area for that, in which case we'll be coordinating out of necessity by phone. But of course, the coordination remains tantamount, and there'd be no sense of like territorial. We genuinely want our patients to be really comfortable with their treatment team, even if it might cross institutional lines, and that's not such a big deal.
100%. 100%. Yeah.
So I'm trying to be mindful of time, and I know I had a call from a patient just prior to this event who had a question, so I want to make sure I get to that. What we have not gotten to, but what I am hopeful at another time we'll be able to discuss, is the role of radiation therapy in palliative care, not to be confused with hospice care, but supportive care. I think it's a really important piece that we did not talk about. And then one of the other things we didn't talk about was oligometastatic or oligoprogressive disease and the role that radiation oncology plays there, which we could probably have an entire living room session on either one of those topics all by itself, because I think they're incredibly important and there's so much to talk about there. But I do, again, want to be mindful of time and all the beautiful desserts that some of you brought today. For those of you at home watching, so some of the people local here, I don't know what kind of phone tree they're on in deciding who brings dessert every month, but it looks absolutely fantastic. So if you're at home, and even if you have a cookie, I suggest you go grab it after this meeting. But I do want to ask this question before we close out with some housekeeping and some up next. So this is a woman who had radiation therapy 5 years ago. And she had shortly after, she had a couple weeks of consecutive sessions, developed some fibrosis. The fibrosis, per her, has continued to sort of grow. This is scar tissue that we're talking about, right? So her question is this progressive? Is this something that will continue to grow? Is there any type of treatment or interventions that she should be looking into right now?
Yeah, so this is a question for the radiation oncologist. Yeah. So even with the most targeted radiation, so like stereotactic body radiation therapy, SBRT to treat stage 1 lung cancer, we always see fibrosis. I actually refer to it as the blast zone. People have heard me say that. And essentially, our goal, of course, is to ablate, to eliminate the cancer cells, but where we gave the radiation is actually going to be scar tissue. And scar tissue stands out very brightly and starkly on a CT scan, and we see it all the time, 100% of the time. Our expectation, though, is that the risk of that being symptomatic, something that a patient's going to notice in their life, not just on the scans, but something that they would notice, should be less than 5%. Otherwise, that patient is arguably not the best candidate for stereotactic body radiation therapy, and there's ways for us to model and predict that. That's called grade 1 pneumonitis, something you only see on the scan. For a patient to notice it is grade 2. For a patient to need medications, grade 3. Hospitalization, grade 4. And in the rare event of demise due to it, which is almost unheard of in the modern era, would be grade 5, okay? Now, usually by about 6 months, the extent of the fibrosis, the scar tissue, is fixed. So it's actually really unusual to hear it continue to progress. It might make me think that there's something else going on, perhaps even another diagnosis unrelated to this. So this patient should be evaluated by a pulmonologist, lung specialist, not necessarily a cancer specialist, to really broaden the net outside of oncology. It happens all the time where patients might attribute a symptom or a finding to their cancer treatment or the cancer themselves, when in fact we need to take a broader lens. And it's very appropriate to say, talk to your primary care doctor, because they will think in all areas. Another specialist that might be relevant is a rheumatologist. So this is a specialist in autoimmune. And speaking of immune, I'm wondering if the patient's on immunotherapy, which has its own pneumonitis, its own lung inflammation. And so I will admit it's very unusual. So as to the specific treatment, it would really depend on the underlying cause, but that's not typical. Usually with radiation, the extent of the fibrosis is fixed by 6 months. Yeah.
Okay, I think that's helpful. And Anna, if you're watching, let's get you set up with a pulmonologist. I think she is watching. I think that's incredibly helpful. Thank you so much. I do want to do one final around the room to make sure that nobody has any questions. We're good online. Thank you, guys. Thank you so much for coming out and having this conversation with us today. I know how much it means to our community. I know how much it means to me. I know how much it meant to my mom. Which is at the forefront, obviously, of my mind right now, that we continue to bring to you guys updated what's happening now and in real time information about your options so that you can, again, make those informed decisions. So thank you both so much. I'm going to do a little bit of up next, our next Gathering Hope. For those of you who have not participated or don't know what that is, we started this at the beginning of COVID, because I think a lot of you will remember this used to be a 2.5-hour deal. Like, we'd come early, we'd record the whole thing, we'd have these around the rooms, these conversations you guys would bring to us and to one another, maybe some challenges or successes that you were having, throughout your experience. And COVID disallowed us to do that. And so our very own Michelle Zay back there, the Tuesday before this meeting, hosts an online version of that very thing, and that's Gathering Hope, and it's at 11 a.m. Pacific. If you haven't joined and you're interested, I highly recommend it, because I hear nothing but glowing reports. Our next Living Room is October 21st, and it's going to be a little bit different in nature in that we're bringing some very close friends of the foundation, the Young Lung Cancer Initiative. They're out of Kentucky, and they are doing some, to quote Bonnie, badass work in generating awareness around this disease, destigmatizing, taking smoking out of the equation, talking about, like, this is the face of lung cancer. One of the things you guys have heard us talk about, we know smoking rates have decreased, incidence rates have decreased in men, but they have increased in women, particularly young, otherwise healthy, never smoking women. What is going on? And they are really just nailing it. So we're going to have them, as well as some young lung cancer patients, come in and have a conversation with us about their experience and how it might be different. A lot of them are raising young children and trying to manage careers and some of them thinking about fertility and what that may or may not look like for them. So it'll be a fascinating conversation and bring a really different perspective. And we are incredibly excited to welcome them to this. I want to give a shout out to Penn Media, not only for what they do every month, and they come in here and they get everything set up so that we can broadcast this live around the world, but also for the beautiful flowers that are right here behind us, for sending those today. That was incredibly thoughtful and meaningful, so thank you guys. Thank you again to all of you in the room, those of you watching live, those of you who will come back post-live. Thank you to James from Onyx and Ash for the beautiful work he'll do after this in editing and creating segments. Michelle back in the corner she's always in the corner, for ensuring that the logistics and that we've got the speakers and the topics and that everything runs so smoothly. We simply could not do this without her. Obviously, the GO2 team. And then I would be incredibly remiss in not thanking our incredible supporters who, without them, we would not be able to bring this and other programming to you. And it's a long list, so I do have to read this. Abbvie, Amgen, AstraZeneca, Bayer, Boehringer, Ingelheim, Bristol Myers Squibb, Foundation Medicine, Genentech, Johnson & Johnson, Merck, Novartis, Novocure, Regeneron, Revolution Medicine, and Takeda Oncology. Thank you all so very much for believing in us and believing in the work that we're doing to support this community. And we'll see you guys all next month. Let's have dessert. Thanks, guys. I wanted to...
So I'll be brave if you're brave. I'll be brave, but only if you're